let's go first to Catherine, please.
Hi, everybody. Happy Friday morning, afternoon, or evening, depending on where you are. Delighted that you are here with us today. We're super excited. We haven't seen you for a couple weeks, so it's great to be back together again. Just to remind everybody that we record these OOBs, these online briefings, and that they do get posted on the 4SD website. So if there's anything that you say that you don't want to have made public, just let us know and we'll edit we'll edit the whole, sorry, we'll edit my brain is not giving me the word. We'll edit it. And I'll make sure that my email address is in the chat for that purpose. Additionally, I want to thank, as always, Live Illustration for being with us and to welcome them. And thanks so much. We'll call on you, Camille, at the midpoint of the session to give us a little bit of an explanation of your beautiful illustration, and then again at the end. And just to remind everybody that those illustrations are also posted, and I encourage everyone to go and look at them. They are fantastic. We have the whole history of Live Illustrations work on the 4SD website. So I think with that, it's been a big couple of weeks. The numbers are high and there's a really kind of complicated set of thinking. And I really look forward to hearing David's thoughts on COVID today. David.
Thank you very much, Catherine. We will stop at the top of the hour. It's currently 17:36 in Geneva. We will stop at 1800. We will look at the Aubrey illustration, and then we will have a discussion. If you would like to be coming early in the discussion, please let us know by putting something into the chat. That's the easiest way, and our colleagues harvest the chat and then present it to me. Now, we are still, as a world, in the midst of a pandemic due to an extremely dangerous virus about which an awful lot is still unknown, and which is going, I believe, to continue to cause societal and economic damage for months, perhaps years to come. My general message to everybody is that this pandemic is global. The virus is demonstrating its capacity to surge with increased numbers of cases, and in some cases resulting in quite explosive outbreaks around 3 to 4 month intervals. And right now surges are occurring in China and in the Indian subcontinent. My conviction that this is a dangerous virus comes from the consistent work that's being done to demonstrate that persons who have had COVID are at high risk of long-term illness and disability, and that there's also, in people who have had COVID, a risk of an increased incidence of cardiovascular events. This is not a trivial virus. There's just insufficient information about it to determine that it is trivial. The absolute need for those who are seeking to enable societies to coexist with the virus and its variants is to know where it is. But you can only know where it is if there are good quality assays being done and accessible to everybody. And with the reduction in the availability of free of charge testing and the scaling back of PCR testing facilities around the world, plus a constant ambiguity about many governments as to whether they wish to make lateral flow antigen tests widely available, the current challenge is that nobody really knows what is going on. And so in the past, we could look at the incidence figures of cases per day or cases per week as reported to WHO and feel that we were probably getting a rough idea of what was going on, albeit an underestimate. Now that is just not feasible because so many countries have decided to follow the lead of the relatively advanced, the countries at the front end of decision making. They've basically decided to scale back on testing in the expectation that by scaling back on testings, you reduce numbers, and by reducing numbers, you reduce the disincentive for people to restart their economic lives. And if economic lives restart, that will basically reduce the general sense that we are having to adapt to the pandemic. And that overall means that the line is that societies will get restarted anyway, and that given that some of the current variants are not causing high levels of severe illness and death, and given that there is a reasonably high level of immunization plus quite a lot of post-infection immunity, that will mean that there will be an uncoupling of illness and death, and that will mean that societies can live with the constant burden of COVID infection and get on with things. The only trouble is that doesn't really take account of long COVID and the potential that as a result of long COVID and other post-COVID syndromes, what's actually happening is quite a build-up of susceptibility to further illness of people, perhaps 1 year, 2 years, 3 years, 4 years after their initial COVID infection, stuff that has not yet been economically factored in to a lot of the decision making. What I've been saying, and you're familiar with it, but I'll repeat it, is that in responding to any infectious disease, the only way to proceed is with people as partners in the solution, dealing with a virus which is a common adversary. So you don't blame the people, you blame the virus, and you organize the people so that they are a capacitated and inspired response community. In Ebola, as I've told you before, we saw this time and time again. The corner was turned in Liberia when Ellen Sirleaf Johnson, the president, mobilized multiple senators at county level and got them to work with local leaders, be they political leaders or religious leaders, to themselves organize to deal with the Ebola in their counties and to empower people to be able to resist the problems caused by the disease. But in dealing with COVID, in many situations, the style of response has implied that people are the problem. And if the moment you imply that and you decide that you will organize the popular response through various mandates or coercive actions or the like, whilst that might feel comfortable from a public health perspective, it can, especially in situations of political disagreement, lead to a quite rapid expropriation of response decisions into political formats. And so what to do about COVID becomes something that is debated politically and perhaps then inserted into legal processes that are linked to political decision making. Perhaps the one example that I would like to share of that happening is the recent decision by a judge in Florida, somebody called Catherine Kimball Mizell, that Catherine's a district judge, that the Centers for Disease Control in the US had exceeded its authority and failed to follow proper rulemaking procedures on federal mask mandates for airplanes and other modes of public transportation, to the point where it is reported that on at least one passenger carrying flight in the US, when the news of the judgment came out, the airline crew broadcast to passengers on the plane that as a result of those decisions, everybody could take off their masks. This was mid-flight. Not exactly going down well with one particular passenger who had started chemotherapy for carcinoma the previous day, and who really did not feel that anything had materially changed on the flight to make it warranted that the airline crew should tell people that they could remove their masks. I am reaching the conclusion that very strong incentives, legal mandates, and other kind of measures that restrict the room for manoeuvre for individuals and put the responsibility onto the state may be incredibly fragile in the current situation, as long as it's becoming increasingly difficult to have debates about what to do on public health issues taken out of the political arena. I mean, what's going to happen now? Anytime there is a public health effort to ask the majority to shift their behaviour in order to benefit a minority whose health might be at high risk, anytime that is liable to being challenged in courts, that's going to make the practice of public health increasingly difficult. And I believe it's one of the things that we who work in public health will need to work on, because it will require some rethinking of the social contract under which public health works. And it will also require some rethinking about the way in which, when public health decisions are made, there is dialogue amongst the different actors with responsibility in advance of decision making, in order to reduce the risk of the possibility that the kind of legal action that has been taken in Florida is applied more widely and might lead to really unfortunate results in terms of public health and safety. I'd also like to move to a couple of other points that I want to reflect on with you all. I mean, what is public health going to be like in the next 10 years if public health professionals are going to be looking over their shoulders all the time at the judiciary, at the legislature, and indeed at social media, and the possibility that social media is used to recruit people who will go and actually seek to physically harm public health professionals, as Dr. Tony Fauci says has been happening to him. I mean, what are we going to be positioning ourselves as? What's going to be the authority under which we work? Well, my own view is that it'll be necessary, actually, for people working in public health to go back to the value systems under which they operate, to go back to the language of human rights and the covenants that have been agreed on human rights in different organs of the international system. It's going to be necessary for us to look at other values and ways in which they can be articulated. I mean, quite often in public health, people refer to the Hippocratic Oath and other such principles. Will we need to look again at any underlying principles or mission statements for public health in, for example, the associations of public health, the APHA, or the Faculty of Public Health Medicine in the UK? I don't know, but I'm certainly thinking about it and sometimes talking about it with colleagues. I mean, yes, public health people also got to be much, much better at communication. mean, we have totally failed to communicate with decision makers that when you have a challenge that increases in magnitude exponentially, it is absolutely essential to act robustly and rapidly in order to reduce the problem before it increases markedly and leads, for example, to vast amounts of virus in populations. After all, the delays in 2020 in Western Europe almost certainly will have contributed to the enormous amounts of virus around in Western Europe and then in North America. And that in turn will have led to an enormous pressure on the developing world, who, even though they tried very hard to act to limit the spreads of the virus at the beginning, eventually had to open up because their economies were suffering and, of course, have been exposed to awful lots of virus. And indeed, one could argue that the position for China has been made essentially very complex indeed because of the ways in which Europe and North America have chosen to go about things. So we need evidence-based narratives that are capable of explaining risk to decision makers. We need a good narrative on how the virus is evolving and mutating, and also clarity on what we're learning about the virus over time, particularly its capacity for surging and the way in which those surges are linked to susceptibility in populations, and how our understanding of susceptibility is greatly increasing as we appreciate that in some individuals the fading of immunity after immunization and after infection is remarkably rapid, a matter of a few months, which may explain why there are certain individuals who seem to be getting repeated COVID infections in a matter of weeks. They just cannot maintain humoral and cellular immunity at the level is necessary. Now, we've said in Forest D and in WHO that if people are the solution, then there are 3 P's that matter. 1, prevent transmission, especially when levels of virus are high. Apply public health and safety measures. Wear masks, well-fitting. Practice physical distancing. Ventilate. Do good hygiene. There's no excuse for people to drop these precautions where you're running with high infection rates. All of them reduce risk, and long COVID is so horrible that we want to help everybody to avoid getting it at whatever age they are. Second, protect people at very high risk. We know that risk of sickness and death with these viruses greatly increases if you are old, greatly increases if you've got diabetes or cardiovascular disease, greatly increases if you're immunocompromised. It also increases proportional to the level of infection that you're exposed to. So health workers are at high risk, security staff are at high risk, people who drive buses are at higher risk. And the whole process about protecting those who are at high risk involves changes to the behaviour of the wider population. So the issue around mask wearing is not to do with the safety of the mask wearer. The issue is to do with the safety of the person who's exposed to the mask wearer. My second P is protect, protect, protect. Protect those most at risk. And we have a beautiful set of tools for protecting people at high risk. We can immunize. And these vaccines, what do? They stop people at high risk from dying. And that's what we need to keep reminding people. These vaccines are not for stopping the pandemic. They do not stop transmission of the virus, but they do stop death. And so The whole point about vaccination is to concentrate it on the people at highest risk, the people whose risk of death is greatest and for whom fading immunity comes quickest. I also want to stress, given who's here on the call today, that I believe that another good way to protect people at risk is to make sure that they take medication that deals with the ACE system on their cell walls and therefore that can reduce risk. And that means statins and angiotensin reuptake blockers and other similar medications have a role. They have not been given adequate attention, as far as I'm concerned, in the efforts to look for therapeutic measures. For me, if it's true that the combination of a statin regime with immunization, with mask wearing and physical distancing, will lead to a great deal greater protection for people at high risk than not doing it. I mean, if that's the case, then everybody should know it and it should be practiced, because the challenge of fading immunity is so big. We do not believe in the WHO or in myself that simply relying on one intervention like vaccination and ignoring public health and safety measures is a good way to go. My third P of my 3 Ps, and I'll revise them again in a minute, is prepare. If we accept that the way this virus is going to manifest itself is through surges at intervals, 3 to 4 monthly intervals, then what we need to do is to prepare for those surges. Whole of society preparedness, bearing in mind that because it's primarily droplet borne, the surges will be localized. And that means that you need to have in any community the capacity to pick up a surge that's coming and to report it rapidly, but then to have an integrated local level response to the surge, which can, if necessary, restrict movement in a local population in order to then deal with the surge without having people travelling far and wide and centrifuging the virus into different parts of the neighbouring population. So you do some localised movement restriction. And as I've said before, you concentrate on preventing transmission and interrupting transmission through the use of isolation. You concentrate on reducing the numbers of cases to spread by tracing contacts and isolating contacts. And you concentrate on identifying those who are at particularly high risk and protecting and supporting them. And this preparing for surge might be the most important part of what I call being COVID ready. So to my final points, people are the response. You need to prevent transmission when levels are relatively high. You need to protect those who are most at risk through immunization and adding to that through treatments if those treatments reduce the risk. And you need to prepare for surges by making sure that there is good local level integration to respond to those surges and to practice isolation as your primary means for interrupting transmission. Last point. We are living in many countries where decision makers have got themselves into a tangle because they have not followed the advice that they have been giving to others, especially when that advice is backed up by legal provisions that can get decision makers into trouble. They may have to resign and go through other penalisations. And my own view is that, quite honestly, that is right. We have a challenge here that if people are the response and the role of the state is to keep people on side, then leaders have to be super careful to be honest about what they're doing, to be humble about how much they can do at a time when we know so little about the virus. They need to be holistic in their approach, recognizing it's the whole human being that's caught up in this virus. They need to recognize the whole of humanity is at stake, particularly poorer people. And I believe they should be hopeful because humanity is capable of solving these kinds of problems because as animals, the human animals work super well when they're together and connected and able to build on each other working in synergy. So that notion of honesty, humility, holistic responses for a problem that affects the whole of humanity, but particularly poor humanity, and one where we should be hopeful because humans have a lot to be hopeful about. Those are the characteristics for authentic leadership, which is now needed more than ever. And people residing in Britain will have, I think, picked that up and may even want to talk about that today. Thank you. And now I'd like to go to Mihika and Catherine, who between them will be leading us into the second segment.
So you guys always get to hear from me at the middle. Maybe I hand off to Mahika for a second. Mahika, do you want to take it away and run us through the first stage of this illustration and our midterm?
Hi, sure, yes. So can you hear me? Yeah, I'll just share the illustration. Hi, Cami. Okay. There you go. I don't know if you want to explain, if you want to start by explaining a little, Cami.
Hi. Sorry, I'm not sure if you can hear me. Okay.
Yes.
I just sorry. I'm just always drawing, so it's always a bit weird to. I don't know. I just picked on what Dr. Nabarro was saying on the fact that we're still in the midst of a pandemic, but the world is.
Yes, I really like the COVID and the world wrestling.
I know, I
between each
like the
other.
arm wrestling. That's cool,
Yeah.
right?
Well, I think because the problem is like people are focusing also on other problems that are happening in the world at the moment. So it's, but yeah, it's.
No, it's great. I also like, this is the first, I mean, maybe I'm wrong. We've had many of these. You guys have been so great, but I kind of like the umbrella for protect. We've not used that before. And maybe that's a thing, Mahika, we could think about working into our speaking points and our messaging. I really like that. Thanks so much.
Thank you. I get a bit tired of throwing vaccines. So I'm trying to find other solutions. But
right? Yes, I understand that.
Okay, that's lovely. Thank you, Cami. Everybody, we are really benefiting from colleagues from Live Illustration joining us at intervals in these sessions. And thank you, Catherine and Mahika. And like Mahika, for you to come in at the end. John, I'm going to ask you to come in the second half. I'd like to welcome Felix Graham Jones. It is just too much. Thank you to see you here. Now, David Fenson, I want to come to you first, just because you are one of my total idols and gurus, and just ask for you to comment in whatever way you'd like about what you've heard. I'm also going to come to Claire Rayner, regularly with us, and I'd like to go to Annie Feltham as well. Iman, I see you've lightened up your thing. I'll come to you fourth.
Can you hear me?
Yeah, okay. Perfect.
Thank you, David. I have not been a participant in previous conversations, and so you'll excuse my sudden appearance here today. But I did think it was perhaps it might be useful for me to make an appearance. This past week, I read a very interesting piece on Medscape, which some of you may know. The title of the piece, written by a science journalist named Arthur Allen, is Why Cheap Older Drugs That Might Treat COVID Never Get Out of the Lab. And I have written in my little chat box the same question: why do inexpensive older drugs that might treat COVID and save lives never, and I emphasize never, get discussed by responsible physicians or investigators or international health agencies, including the World Health Organization? Why is this so? For those of you who might be familiar with me, and that's probably a minority of the group that's tuned into this chat, you can find my name and pandemics and statins in PubMed. I've been writing about this for more than 18 years. I published a big paper on this in 2006 in Clinical Infectious Diseases, and David knows so well that I've talked with him about it during the Ebola crisis, which he was deeply involved in, and more recently in the COVID experience globally. I have spoken with Dr. Subramaniam, who's the chief scientist at WHO, personally about this, and I have written to many health officials throughout the world and many investigators throughout the world over the years. I have submitted many papers to journals and found that they get quickly rejected, often without peer review. I sent a paper to the Journal of Hospital Medicine in the United States, the house organ for the Society for Hospital Medicine, of which there are 15,000 physician members, and was rejected in 86 minutes by the clock. The editor rejected the paper. Perhaps he read it, I'm not sure, but he quickly reached the decision that it was not worthy for publication in his journal. Now, I think with a pandemic, every physician, and I'm sure that all of you would agree with me, although everything that David has mentioned is, of course, important, what is really the bottom line is saving lives. If you don't get infected, you don't get seriously ill, you don't go to hospital, you don't end up on a ventilator, you don't run the risk of dying. So that the first order of business in responding to a pandemic should be to find a way to save lives. Now, there's no question that vaccines have saved lives, and there are estimates in the literature that upwards of several million people have had their lives saved because of vaccination. And clearly, many of the public health interventions that have been implemented throughout the world have been similarly effective in saving lives. But my point has always been, instead of a top-down solution, let's approach it from the other direction and fixate on a bottom-up solution, which could be implemented by ordinary physicians practicing in ordinary healthcare systems in ordinary countries throughout the world, particularly in lower and middle income countries, the resource poor countries that have had difficulty obtaining treatments and difficulty in getting supplies of vaccines. And even if they get supplies of vaccine, difficulty in implementing vaccination programs. All of these countries have physicians who know about generic drugs. They use generic drugs every day in their practice, and David mentioned statins and angiotensin receptor blockers and ACE inhibitors, and there are other drugs also, which I've written about if you care to look up some of my earlier papers. The importance of this approach is that it's generic. It treats the host response to infection, not the virus, not necessarily the virus, even though statins, we know, have antiviral effects. And it could be used in any pandemic. It could be used in any acute critical illness. For example, patients with sepsis, patients who have community-acquired pneumonia, patients who are suffering from smoke inhalation. And there is an experimental literature on that very topic. People who have acute lung injury following crush injury, as occur in earthquakes. And lots of situations in which we have acute lung injury developing in patients who are experiencing acute critical illness. We have a host response that is very energy dependent, hugely inflammatory, and which can be modified with generic treatments. There is a rich experimental literature and even a clinical literature on using some of these drugs and treating the host response to many of these conditions. And if you read carefully the experimental literature, you can find that it is a viable option, particularly in a world where we don't have effective treatments that are widely available for treating a disease or a pandemic like COVID. There is no universally available treatment, particularly in low and middle income countries, that is widely available and could be used every day by ordinary physicians in these countries. Now, why is this so? Why is there no curiosity among the expert physicians, investigators, and health agencies? And I include not only the World Health Organization, but I include Médecins Sans Frontières, I include the Wellcome Trust, I include the Gates Foundation, and many other notable non-governmental organizations. There's just no curiosity to deal with the question of, number one, we don't have a universally available, inexpensive treatment for COVID that could save lives. And there's no interest on the part of anyone in asking the question, well, maybe we ought to investigate it. Now, there are already at least 13 observational studies that show that statin treatment is associated with a decline of about 50% or more in mortality due to COVID patients, due to COVID. When you combine a statin and an angiotensin receptor blocker or an ACE inhibitor, you can get a 2/3 or 3-fold reduction in mortality, the risk of mortality, as shown in one observational study that was conducted in Belgium. Why is nobody picking up on this possibility, particularly when we don't have other treatments available? And I would like to have the views of all of the people who are tuned into this, this chat on why no one is curious enough to ask the question that these treatments might just work. They might be applicable to anybody who is seriously ill, and particularly those who are hospitalized, and particularly those who live in low and middle income countries where these drugs, these generic drugs, which I talked about, the statins, the ACE inhibitors, the ARBs, are widely used by physicians all over the world. They are inexpensive and they are abundantly available everywhere that you have a basic healthcare system. Full stop. So let me have your thoughts, please.
And if anybody wants to be in touch with David sideways, just put something in the chat or use the LinkedIn group, because it's very worthwhile. And I've become more convinced of the need to focus on this since it's become clear that past infection and immunization does not give you lifelong immunity. So you need something else. And my other point is that dexamethasone has been found to reduce death in people who have COVID, and that's basically adopting the same approach, but it's not. It's a rather messy drug. Why, if dexamethasone was trialled and found to be useful, why isn't there attention to ARBs and statins? I just don't know. We had the same question from Professor Christopher Edwards, who was an internal medicine endocrinologist, from Newcastle, who found that spironolactone made a difference as well and couldn't get anyone to pay any attention. We have some clinicians on, clinicians are active. Claire, you're moving. Are you going to unmute and talk?
I am, sorry, I was just typing a message that I would like to be in touch, because there are a bunch of us physicians in the UK who are asking the same question over and over. Where's the curiosity? So I'm really hearing that and agreeing. Yeah, I think we need to look at all options, especially the cheaper, readily available ones, for preventing infection, and when getting it, getting the treatment in early. I just want to agree with your summary about where we're up to with long COVID as well, David. It's a question of, we are finding that people are getting more ill after 2 or 3 years. And just in response to the public health issues, I love public health, as you know, but somehow those messages are being drowned out, or perhaps the public health voice has been devalued, I think, over recent years in the UK. And I just think we somehow need to find ways of getting those messages across. Even in my own family, there's massive confusion. My brother was saying to me at Easter, he said, look, we did what we could to protect the NHS, but the NHS is overwhelmed, so it hasn't worked. What are we supposed to be doing? And the fact that the health services are overwhelmed is being covered up, and that's part of the problem. And I think part of the reason that we have no curiosity about things is because if it doesn't cross people's field of vision, it doesn't exist. So I think those are my comments for today, and just thank you both for the things you've said.
Well, pleasure. Thank you, Claire. David, Claire's with us regularly. She's one of the pioneers on long COVID, picked it up very early on and advocated for the issue to be taken seriously. Claire's an occupational health physician based in the UK and has teamed up, managed to get WHO to be a little focused on this. Would anybody else like to address David?
Let me,
Yeah.
David, if I may, please.
Yeah, come in.
Let me just say that one of the things that my colleagues in Belgium and I have pointed out in our paper describing our findings on the threefold reduction in the risk of mortality with statins and ACE inhibitors or ARBs in the treatment of patients with COVID is that by treating patients who are hospitalized and even treating all people who test positive, no matter where they are tested for COVID, we might just possibly prevent long COVID. We don't know this, but that is an important question. And because it's an important question and we don't know what causes it and we don't have a treatment for it, we need to be asking that question. No question about it. The question itself is important, and it just stands out as something that might possibly be affected by generic treatment, treating the host response, not the virus, the host response. Now, what's important about all of this is that this approach is really based upon evolution, okay? Now, I've written about this. I wrote about it in 2018. And in fact, an investigator at the Harvard School of Public Health and I began talking about it back in 2010. If you think about children and adults, children seldom develop serious illness with COVID infection, okay? They're wonderful transmitters, but they rarely get seriously ill and rarely require hospitalization. Now, we have a lot of papers that have been published on severe COVID in developing in children, but it's in a very small proportion of patients, usually those, very often those with some underlying immunocompromised condition. Now, why is this so? You know, back in 1918, with the influenza pandemic worldwide, we saw the same thing. Children lived, their parents died, okay? Why is this so? And what is the cutoff between children and adults? Well, my colleague at Harvard said, well, I can study that. We can take mice and give them experimental influenza, or we can give them experimental sepsis with lipopolysaccharide injections, and we can give the same infection, the same treatment with LPS to children and adult mice before and after puberty. And we can see what the survival rate is. Now, surprisingly, no influenza virologist had ever thought to give influenza viruses to mice that were children and adults, that were pre and post puberty. But he did it, and he published with his PhD student in 2017, and I summarized his work and the rationale for the host response that was very different in children and adults. I mean, in his findings, about 15% of mice that were pre-pubertal died of influenza, whereas those after puberty, about 85% of them died, okay? Now, what is the difference? The difference was about 2 or 3 days in terms of the lifespan of those animals, but it was puberty, which was the time when everything changed. Now, all of the people who are tuned into this chat remember what it was like to go through puberty, okay? That was a very, very big event. And it's a very big event physiologically for all human beings and all animals, including mice. And here we have a perfect example experimentally that demonstrates that children have much better survival from experimental sepsis, from influenza, and probably from COVID than do adults with the same infection. Okay? Now, this is evolution acting right here. Okay? Nothing more. It's a simple explanation for something that's very complex and which we don't fully understand. Why don't we take advantage of this and roll back evolution, roll back the whole host response that is damaging in adults, and where we can create tolerance to the infection among children, among pre-pubertal animals of any kind, whether they be mice or human beings. This is what we're trying to do. This is what treating the host response with these drugs can do. I'm convinced. And we need to have the curiosity to ask those questions of adults, children, both, and see if we can't have an impact on the global mortality impact of COVID, which has been estimated to be well over 20 million in a very good paper published in Nature within the last few months. 20 million deaths without a therapy are 20 million too many. And this is a statistic which I think is shameful for us to even have to deal with, have to recognize. But it exists. These are the facts. And we need to do something about it. And we need to have the curiosity to do the studies and to put into the hands of practicing physicians the bottom-up approach to treatment of the host response to those who develop serious pandemic illness of any kind.
Thank you very much, David. And every time I hear David, but perhaps today more than ever, I am inspired to try harder. I've not obviously succeeded, otherwise he wouldn't be here.
I haven't succeeded either.
No.
And I've been at it for a much longer time than you.
Yeah, of course. Okay, please come back, David, again. Let's just go round. I did want to invite John Atkinson to comment on some other factors of what we've been discussing this morning, this afternoon. And just while John is talking, if anybody else wants to say a quick thing, either raise hand function or just simply unmute yourself and shout out. John, please, first.
David, I'd like to go back to your comment about how we learn well, super well together. That humans are social animals, and it's that social learning that really differentiates us, where our curiosity takes hold and spreads, and others work on it, and things start to proliferate and amplify as we go forward, because it's in our communities, in our networks, that we find reservoirs of both knowledge and know-how. What do we know, and how do we know how to use it? And those two things are really critical. And I think the challenge that you described in terms of the messaging for public health is it's a message for it's being described as a message for public health. It's not a message. We're not describing it as a message for government. It's a message. It's a leadership message that needs to say, not what's in it for me, you don't have to wear a mask anymore, but how do we take care of each other? Because it's our care for each other that enables our curiosity to take hold. It enables us to do the right things in the right places. And the message, rather than being, you don't need to wear a mask anymore, being, we advise you to wear a mask, particularly in confined spaces or where you're around people who are susceptible, is a very different way of describing the same thing. So how do we take care of each other is an important strap to hold on to, and it's one that works in all sorts of situations. And I go back to my military time, David, where it was the fundamental premise for all of us. How do we look after each other? And I think that gets a little bit lost in the individualistic focus that seems to have taken over.
Super good, super important. Thank you. Richard Longhurst is unmuted. I just want to check whether he wants to speak.
Thank you, David. Hello, everybody. No, I just want to raise this, flag this as an issue, maybe this is something we could talk about in a few weeks' time. There seems to be this convergence of issues. Cost of living crisis, it's not going to get any better. Food prices going right up. People cannot isolate, cannot give up their employment, self-employment, cannot isolate. So just to flag that point as perhaps something we can talk about in a few weeks' time.
Thank you, Richard. Had the conversation gone a different way, I would have used the opportunity to update everybody on my work that I introduced 3 weeks ago as part of the United Nations Global Crisis Response Group. We've come together around food, energy, health, education, and finance as being areas in which really multiple millions, in fact hundreds of millions of people all over the world are already suffering from increased discomfort, pain, hunger and more. And it's accelerating and becoming nastier in many settings. And it's part of what we've seen with COVID, which is just a widening gap between those with wealth and advantage and those who have less. Richard, thank you for raising it, and we'll come back to it next briefing. I saw Peter Hebert light up. Peter. Iman, are you alight because you'd like to speak? Because I can come to you next as well after Peter.
Yeah, I just wanted to pick up, as well as an engineer, I'm a turnaround manager. And at the beginning of this, I said, we should look at the things that achieve the most for the less, for the least cost. And, obviously from that point of view, looking at as you've said, masks obviously achieve a double function, but they also catch it where it originated. Equally, in terms of transmission, you can disperse it, you can kill it, or you can filter it, but actually killing it is the cheapest. Filter media costs a lot of money. And I think the same approach applies to isolation. you can isolate by locking everybody away and stopping them working, but you can also teach them how to isolate while they're carrying on doing their job, wearing best masks, keeping their distance, and so on. And that was the common theme I saw of what's just been said already. And I hope
Very good.
that is the way we should go in the future.
Thank you, Peter, as always. Iman, did you want to speak?
Thank you, David, and hi, everyone. I just wanted to share my concerns around what I see happening in Ontario and in the disjointedness of our policies at federal level from our what's happening at the provincial level sometimes is not in tandem with the federal public health policies. And this is putting us citizens at loss many times. The second observation I'm seeing is we're kind of chunking out public health policy at provincial level, dividing it into smaller chunks of mask wearing in schools. And that is pushed on the Ministry of Education to decide. And then teachers in schools are voicing their sufferings, but in isolation from the bigger community of public health. Doctors are also being divided into smaller groups. I'm noticing something a bit alarming to me personally, that doctors are taking off to Twitter to share the knowledge they have, the concerns they have about pandemic spread, telling people about the 6th wave that we're now in. And it's not being communicated as robustly, as clearly through the official channels. And that is problematic, and more stories of retaliation are coming out against doctors who voice their concerns or who lead campaigns to do this or that in terms of sort of steering public health policy back towards better fighting of pandemic. And on top of all of this, I mean, it's fragmented leadership, basically. We are departing from the basics of public health. At the beginning of pandemic, we spoke about the need to do the basics and always get back to the basics. We are departing from surveillance. I don't even know, as a public health specialist, I don't know what pattern of surveillance that we are using right now. It doesn't conform to any science. It's not evidence-based. It's patchy, it's sporadic. And another concern I have is the responsibility being pushed on the individuals. Time and again, anecdotal evidence is that you develop symptoms, you stay at home. The advice is stay at home, don't come to facilities. You go on government website to access testing, and there is a list of exclusions. So now the rule is the exclusion. Everyone is excluded except for a very narrow category or sector. But you don't even get this, it's not clearly spelled out. You face it as an obstacle when you develop symptoms. So access to testing is difficult. And then the rapid antigen test is distributed in some pharmacies, but not all. Those pharmacies, you need to go on the websites of the specific retail pharmacies. So it's more and more outsourced to and privatized. The responsibility is pushed on us to seek out. While this is public health, this is not private doctor issue. And faced with obstacles, accessing testing is one story. PCR is nearly non-existent. People are discouraged from going to the hospitals to access PCR. So more and more obstacles, more and more pushing of responsibility on the people. Lack of communication. The basic public health messaging is now being obscured, and definitely it's a balance of interests in terms of, as you rightly mentioned, the reopening, the marketing of the idea that when businesses reopen, we will get our economy back. And then we're talking more about our inflation and about our crippled economy as a result of the pandemic, more than just sharing the information and allowing the public to judge for themselves. So even basic data is not being collected My concern is not about the data not being shared, about us intentionally manipulating our public health policy not to collect the data. So we are pushing ourselves into a dark corner of ignorance, lack of knowledge. How can we make evidence-based decisions if we are not collecting the evidence? But this is where we are now. Thank you.
Thank you, Iman. We have to stop, but I see a couple of people have got hands up and lights up. I mean, I think many people, we've worked with Iman before, but that was possibly the most outspoken. We've heard you, Iman. Thank you. Joe Nichols has written a similarly troubled message from Nairobi, and in his social media postings that I've seen, NK Seti has said not different things from the situation in New Delhi. And so this is really important. Annie, do you want to say the last word? We'll have to stop now. We're over time.
Okay, well, I think it's a request listening to everybody. My question was initially, how do those concerned with COVID actually get heard and they're not getting heard now? What I'd really like to hear from you for the next session is an introduction to this joint initiative from the UN, which you talked about, and I thought was really interesting last time. And if we could start on this, and I think that the UK experience informs that work. Because now that and I think this is the key, now that COVID is no longer seen as an emergency, it's pushed down the agenda so that it's just in the rough and tumble of all the other things that we see as priorities, so that the politicians then are talking about the crisis in the war in Ukraine, the cost of living crisis. And so how do we fit this together? And I'd be really interested in what people's experience was, because I think in some ways what Iman's just been really interestingly talking about in Canada is a different version of what's happening here. And then I did a quiet laugh to myself when you talked about politicians being penalised, because that could well happen here, but it's taking a while. But there's my request for our future agenda, if that fits in with what everybody else wants.
We work like that. We'll make it happen. Thank you very much indeed, Annie. Is there anybody else who would like to have a very, very, very short last word before we close? I would like you to feel that you're welcome. Okay, well, on behalf of all of us in Forest D, I'd like to thank you, and I'd like to move now to Mahika for showing us Camille's picture again, and for any remarks about the next session.
Hi, everyone. Oh, this is great, Cami. Thank you very much I think it really highlights the importance of communication, testing, knowing where the virus is to be able to protect people. And as Catherine said, the umbrella is great. It means a lot more than just an umbrella, so it's good. For me, this briefing was very special. I think even though it included a small number of us, I think it allowed for a more interactive dialogue and a lively chat. I like the idea of going back to basics, as David had said, going back to what works with COVID. That means test, trace, isolate, to learn from what we know. And then with the conflation of crises and David's role in the global crisis response group, going back also means going back to our values, to common values, not just public health values, basics of governance, but maybe something more simple and just basic human values that make a positive difference to the world. Equity, transparency, consistency, collaboration in our decision making to ensure that no one is left behind. And in our personal lives, that would mean being kind and compassionate and brave in our own circles of influence. So thank you everyone for joining. Our next session is again on the second Friday, so in 2 weeks, which is, let me just check. Yeah, so that'll be 6th May at the same time. So looking forward to seeing you all. And thank you very much.
Bye-bye all. Thank you, Camille. Beautiful. Thank you to each one of you who came, sparing time. Bye.